Good evening, friends and colleagues. Welcome again to our monthly webinar, the InVision Center for Innovation and Precision Eye Health monthly webinar. And today marks the second webinar for year 2024 and having one webinar just before Lunar New Year. So this makes this webinar especially wonderful. And today I would like to, it is our great honor to have Dr. Peter Thomas from the world-renowned Morpheus Eye Hospital, London. And I would like to say a few words about Dr. Thomas before we begin. Dr. Thomas, prior to his medical training, he actually was a neuroscientist and he had a PhD in computational neuroscience from University of Cambridge. And after that, obviously, he went to do his medical degree, and he went on to become a pediatric ophthalmologist, which is his clinical training. And he is now the Chief Clinical Information Officer and Director of Digital Development at Morpheus Eye Hospitals. Amongst his accolades, he was awarded the CCIO of the Year in the annual Digital Health Awards 2022. In fact, he recently founded UK's first Department of Digital Medicine. And he has a keen interest in digital transformation of clinical care, creation of hospital environment, and especially in the area of sustaining technology innovations and automated services. Today, his talk is on building an integrated eye care services, looking into integration, co-management services between ophthalmologists and community optometrists. So without further ado, I shall hand the stage to Dr. Peter Thomas. Peter, over to you. Thank you.
Many thanks for your kind introduction and many thanks for the invitation to speak today. Brilliant to see such a successful seminar series. I can see 292 attendees would be jealous of that at Moorfield, so congratulations. I'm just going to share my slides now. Hopefully when I click share, you will see my fairly plain looking introductory slide. Somebody shout if you can't see it. Otherwise, I won't introduce myself because you've done such a great job of that already. What I'm going to talk about today is a little bit about how the spectrum of clinical services we're offering is changing as we embrace new ways of working. And if we look back to how we used to practice pre-COVID, this is kind of how I like to break down in my mind the different ways in which we can provide care. On the left, we have our traditional ways of providing care in person through traditional clinics, but also increasingly over the past couple of decades through virtual clinics or diagnostic lanes. I'm sure you have a similar model of care where patients come through into a technician-led clinic. They don't see a doctor or other clinician on the day. They have a series of scans, they go home, and then those images and scans are reviewed sometime later. And for 10 years or more, we've been seeing a significant portion of our medical retina and our glaucoma patients in that way. The remote side of things, I think, is where we were really undeveloped prior to COVID and certainly behind some of the work that you've been doing in Singapore. I like to break down remote into synchronous and asynchronous. For those not familiar with this breakdown, synchronous is basically where the clinical interaction is happening in real time. So the doctor and the patient, or the optometrist and the patient, are talking in real time via telephone or via video consultations, which I'll talk about a little bit today, or asynchronously, where it's happening not in real time. That is, data is being collected somewhere else, either via home monitoring or via shared care with an optometrist. And that data is then being analysed within a traditional hospital service or a new type of service in order for clinical decisions to be made and advice to be returned. Now, of course, during COVID, things changed radically. We had a massive expansion of our synchronous remote care. We started to get a little bit better at doing home monitoring. I've kept it as yellow because I don't think we're there yet in terms of engaging with our community optometry partners. But as I'll show you today, we've made huge strides in working better together between primary and secondary care. And this is where we want to get in the future. So I want all of these to be green. I want Moorfields and ophthalmology around the world to be delivering services through all of these channels to make sure we have a good integrated system. I'm just going to skip over a few of the different things we're doing in terms of these different channels. And then towards the end of this talk, I'll start focusing in on particular work we've been doing around engaging with our primary care community. So video consultations, which take place directly between patients and ophthalmologists, were completely essentially unknown in the United Kingdom prior to COVID. At the bottom right of the screen there, you can see a chap called Ian Livingston, who's one of my excellent colleagues up in NHS Scotland. And for a couple of years, he'd been setting up a service allowing community optometrists operating out of practices on the high street to essentially conjure him up, to draw him in remotely into their consultations. So the on-call ophthalmologist at his hospital was available to receive video calls from optometrists in their own practices, and he'd gone as far as to 3D print them slit lamp mounts, which they could put onto their slit lamps. They could place an iPad in there, and they could then directly live stream their examinations into Ian and his consultant ophthalmologist colleagues. And he found that by supporting optometrists in that way, he was able to manage about 50% of urgent and acute referrals without the patient ever needing a visit into hospital. And that 50% number, we find time and time again, whenever we in ophthalmology develop services to support extended clinical care of patients in optometry practices, it's almost always 50% of patients who we can support to be managed remotely, which is obviously a massive improvement for the system in terms of sparing hospital capacity. The images you've got on your screen there, this was what we believe to be the world's first ever live remote examination of an eye. This is me standing outside Moorfields Eye Hospital in the rain, 1 week after London's 5G network was switched on, with a portable slit lamp and a 4K video stream from a mobile phone being live streamed up to Ian at the bottom right there on stage up in Edinburgh. And he was commentating on live examination of an eye. So that was our first sort of starts to move at Moorfields into video consultation. Now, of course, a few months later, COVID became a thing. And we started needing to think very rapidly about how we could support our patients at home, those who were afraid to come into hospital for fear of contracting COVID, and also because we'd cancelled much of our routine appointment. This is my colleague, Pei Lin, who's my clinical director of digital innovation, demonstrating about a week before COVID lockdown, performing an examination of the front of the eye, just using a patient's smartphone. And then we launched that. So 24 hours after the first lockdown happened, after our Prime Minister said cancel all routine appointments and only go into hospital if necessary, we launched our video consultation services. The most successful ones have been our emergency video consult services, which patients can access via our website. They don't need an appointment. They simply go to our website, they click on a link, and at that point, within about 15 minutes, they were speaking to a Moorfields ophthalmologist about whatever their acute presentation was, and we were managing over half of those patients at home without ever needing a visit into hospital. We mapped out all of the emergency services that were available both in hospital settings, but also in primary care settings as well. So in the United Kingdom, we have a system called minor eye care services, minor eye condition services, and the COVID urgent eye services. And those are two ways in which optometrists in their practice can receive reimbursement from the government for managing patients. So one of the first things we did during COVID was to map all of these services so that we knew when we received a video consultation where a patient needed to be seen, we could plug that patient into the best, nearest, most suitable service for them. And that was really one of our first steps into making our new digital services at Moorfields work really together, well together with the network of optometrists working in the community. We did a huge amount of work. Obviously, there was lots of video services during COVID. A lot of them received bad press in our newspapers in England regarding safety. Ours was completely unimpeachable. Within a month of go live, we published an audit of 1,000 consecutive patients and showed no episode of harm or potential harm coming through from that service. And patients absolutely loved it. So the majority of our patients are strongly agreeing or agreeing that they prefer video consultations to in-person visits. Although, to be fair, we did that survey on the first 7,000 patients who were all during COVID, and nobody wanted to go into hospital during that time. So perhaps a little bit of an unfair advantage for video consults. Had all sorts of other benefits as well. We find these environmental and sustainability benefits across all of our services. We've measured them best in our video consult service, and we found that our annual emergency video consultation service saves our patients the equivalent of traveling almost twice to the moon and back in terms of kilometres travelled from not having to come into hospital, and that's equivalent to about 51,000 litres of petrol burned. We have similar numbers to show environmental benefit from patients being managed in collaboration with community optometrists. So the environmental footprinting is really showing that all of these services where we try to offer new digitally delivered models of service, where we try and work together with our primary care partners, are also good for the environment as well as good for the patient. That's an example of some patient feedback we had. Patients absolutely loving the service we offer via our video consultations, and we won awards for it as well, including the Health Services Journal, which is one of our top publications in England, analysing the NHS. Another piece of the puzzle that we've really started working on in the last few years is acknowledging that there are some patients who can be seen in primary care, there are some patients who need to be seen in hospital, but there's many patients who need routine review, for example, stable glaucoma patients, for example, medical retina patients on monitoring, who need regular reviews by visual fields, OCTs, images, but broadly speaking, checkbox questionnaires. So we've increasingly started to deliver those via dedicated diagnostic imaging hubs. We've got 2 operational at present, although the Brent Cross one is just being renovated. So Moorfields at Hoxton is in an old warehouse. All it is full of ophthalmic imaging devices and technicians, no actual clinicians on site there. Our Brent Cross site is actually in a shopping centre. So one of the things our government wants us to do is put more care services on the high street. So we've actually placed one of them directly in an old branch of a shop that was called New Look, that sells clothes to teenage girls. That is now a Moorfields Ophthalmic Imaging Centre, although we're actually just moving to a different unit in the hospital at the moment because our lease is up. So a little bit of change there. That's Sepeng Kaur, who many of you will be familiar with, our most eminent of our ophthalmologists, and alongside our chief executive at the Brent Cross Imaging Hub. And that's been a really exciting piece of work, and I'd recommend at some point you invite as one of your speakers, Paul Foster, who I know you'll be familiar with, who is, again, one of our ophthalmologists with an interest in ophthalmic epidemiology, and he runs this imaging hub in the Brent Cross Shopping Centre as a research site, answering all sorts of questions about what is the most efficient way to deal with patients in high volume. This is an example of the patient geolocation we use so that we're able to track patient movements very precisely around the hospital. So this is some of the real-time data that we extract from patients going through this high volume imaging centre that shows us exactly where the patients are at any given time. We can analyse their flow, and Paul overnight was able to reconfigure these imaging centres in order constantly to try and make them more efficient. And there's been some really incredible findings coming out of that Hercules project, which I believe Paul is in the process of publishing. But I'd recommend him very much as a speaker. It's a brilliant talk he gives on this. Home monitoring is something I'm particularly interested in. So one of the exciting things is the massive profusion of consumer level devices. You can see virtual reality, mobile phones, smart assistants, and now ChatGPT, which can actually play a pretty significant role in the future, allowing us to monitor our patients with very low cost devices that are able to do clinical grade work, which they may already have in their home. You'll be familiar with some of these smartphone apps, and I think you're quite advanced in their deployment, probably ahead of us in Singapore, that allow patients with medical retina diseases, for example, to monitor for relapse. I've got a particular interest in virtual reality. On the left there is the first commercially available virtual reality systems in the United Kingdom. This was back in 1993, I think it was. My father on the right there took me to the first one at a theme park that's near where we live. It was a very underwhelming experience. I was quite a small 13-year-old boy. The helmet was way too big for me, kept on slipping off. I was overwhelmed by feelings of nausea because whenever you moved your head, it was a second before the image updated. So it was a bit of a false start for virtual reality, but things started to get exciting about 10 years ago, when Oculus did its initial Kickstarter campaign, and Google came out with its Google Cardboard low-cost virtual reality headset, which you can see here, and this is 2013. This was my first prototype of a virtual reality test of strabismus. It worked pretty well. It allowed me to do a digital equivalent of the Hess test. We then went on to develop that, so we're trying to replace the test on the left with a virtual reality test on the right. The television screen there is just for the purpose of the photograph, so that you as an observer can see what's inside the VR headset. But it was extremely effective in allowing us to measure different types of strabismus. And this is our most recent version, where we use augmented reality. So we pass through a real image, we cover an eye, and we're able, often in the course of about 60 seconds, to measure the ocular deviation with a good amount of accuracy in any position of gaze we want to. And that's quite interesting because we're all familiar and comfortable with the use of patient and consumer level devices to measure things like visual acuity. But actually now we're getting through the next wave of display technologies, and the Apple Vision Pro is going to be incredibly exciting, I think, as a sort of consumer level augmented reality device that can actually measure eye movements in the patient's home 100, 200 times a second, and essentially perform to the level we would need for a clinical grade device. One of the other things we worked on was an Alexa test for vision. The reason I include that is because the suggestion for this actually came during a talk when we were hosting you from Singapore over at Moorfields a couple of years ago, where Piers Keane said, have you thought about using smart speakers to do home vision testing? So I got one of my PhD students to create a nice little prototype. We've never actually done anything more with it. The sound doesn't work via Zoom on this video, but what you're about to see is we made a simple Alexa skill that displays letters on the patient's screen. The patient calls out the letter they see, and then it runs through a traditional staircase procedure in order to find the smallest letter that the patient is able to see. There's a very long preamble while Alexa was explaining the test to the patient, but here a letter is being shown. You call out with your voice what letter you see, and if you get it right, the letter gets smaller. If you get it wrong, the letter gets bigger. And we did a little bit of early validation of that and showed that it agreed very nicely with a logmar chart that was just above the speaker. But that's an interesting one for the future. And finally, there's all kinds of AI technology which we can use to start managing patients at home. There's some work I did with the William Gates Computing Lab on AI facial landmarking back in 2015. And that's my son, Oscar, who is now 7 years old, when he was, I think it was about 7 or 8 months in this. And he likes to watch Peppa Pig. And his job was to keep watching Peppa Pig, but occasionally I would make Peppa Pig disappear and replace it with a test stimulus. And through the AI facial landmarking, I was tracking his visual behavior and able in real time to understand whether he was able to see the targets. And through doing that, we could assess very quickly what the level of his vision was in a pre-verbal child without needing actually quite expensive tests of pediatric vision. All of this was on a laptop that cost me about £300. So lots of exciting opportunities with AI and home monitoring. Not to forget, actually, paper is also a very good way of testing vision. During COVID, we needed something to cater for our digitally excluded patients. So we rapidly put together a home-based vision test that could be printed out or posted. So shared care with optometry is one of the main things I want to talk about. I think the context is helpful for this. So in England, we have one of the lowest per capita numbers of ophthalmologists anywhere in the Western world. We have a huge and growing population that are getting sicker with more chronic disease. We don't have enough ophthalmologists. We don't have enough capacity in hospitals to manage in the long term all of those patients. We have a very large network of community optometry practices in the United Kingdom. I think around 15,000 practices on the high street. And increasingly, over the past couple of decades, the training for optometrists in England has become very clinical, which means that this workforce has a very high level of clinical expertise, and we need to use them more in order to deliver care. We increasingly see optometry as the front door to eye care. Traditionally, referrals to ophthalmology came via general practice. We're now nationally moving to a system where referrals come in directly from optometry practices. We want to get optometrists co-managing more of our patients, but we need to move on from our current situation. Our current situation, or our historic situation, has been where an optometrist makes a referral to an ophthalmologist and the ophthalmologist takes over care. We haven't been good at maintaining a two-way connection with our optometrists in order to manage the patient together. So some of our sort of recent work on this, led by my colleague Dawn Sim, was using a platform called Big Picture, where we networked our hospital up with a number of referring optometry practices in the south of London. And rather than sending referrals into medical retina, they sent their information about these patients via this platform, including volumetric OCTs and structured histories that the platform helped them to derive. And we found again that 50% number that I mentioned at the start of this. By practicing in this way with optometrists, by utilizing the OCT machines that they have available in their practices, we were able to manage about 50% of our medical retina patients without them ever needing visits into hospital. You can see on the right there a bit of a macular hole as one of the example. I'm going to come back to this model of care at the end of this talk and show how we've been scaling it. So how do we get to this sort of promised land? How do we get to a situation where we're implementing all of these different digitally delivered care services, we're making it consistent, we're fitting it all together, and we're engaging all parts of the eye care sector, which means hospital ophthalmology, independent treatment centres, and high street optometry practices. So if I look at the hospital first, I really like this quotation because it really nicely captures where we are at the moment in hospitals. So attempts are being made to design computerized total information systems to replace conventional paper records, and the possibility of automated diagnosis is being seriously discussed. Now, we're very advanced in terms of that paper record replacement. There's only a few hospitals in the United Kingdom that are still on paper. As you know well from the work that you're doing over there as well, AI is on the precipice of transforming some of our ability to make automated clinical decisions. But the point to be aware of is that this quotation stems from 1969. So this was in a publication in the British Medical Journal 10 years before I was born. And the reason for saying that is that we can talk about about technology joining up the system and improving patient care, but we have to be aware that the technology alone isn't enough. There's many other enablers that we will need in order to achieve this vision of an integrated eye care service. So the first thing we need to do, and this is a hospital-centric view, is the hospital needs to become better at doing digital in hospitals. Just one example I'll include in here on this is that this is a publication from 1976 from Stanford, a system called MySyn. And MySyn was able to outperform human clinicians, so human consultants, at diagnosing the causes of septicemia and recommending treatment. So that is now almost 50 years ago, if I draw your attention there. But what we can see is that in the 1990s, when a review of that technology was published, MySyn was never clinically implemented. And the reason for that is we had the technology, but we didn't have any of the other enablers in order to implement it. We didn't have the right people in hospital who understood how to implement it. We didn't have the digital infrastructure. We didn't have the governance arrangements. We didn't have any of the core enablers. So it's not just about the technology, it's about the people and the processes, and that's often where the interesting challenges are. In England, we recently, so this is going back about 6 or 7 years now, had a government report, and this was called the Wachter Report, led by a very, very esteemed American doctor called Bob Wachter. And he identified from his 10 recommendations, 3 of them, and I've drawn out 2 here, that essentially say, we don't have enough clinicians. And in the case of eye care, that means we don't have enough ophthalmologists, we don't have enough optometrists, we don't have enough orthoptists who are actively engaged in digital transformation. Historically, clinicians have been seen as a group who IT professionals would have meetings with, but that they wouldn't be key in driving digital transformation. And this report was saying that was the reason why England's National Programme for IT, which we spent £16 billion on in the early part of the 21st century, was a total failure. It failed to include clinical leadership in the digital transformation. I did a bit of work around this a few years ago to help define Moorfield's strategy, talking to, it was about almost 40 digital leaders from around England via survey and interview. And we found, so this slide shows an interesting thing. So when we ask the question, in my organization, we have a track record of implementing good IT systems to support clinical care, we find that overall, people agree with that. They felt that their hospitals were good at implementing IT for patient care. However, when we analyze the responses between IT professionals and clinicians, we found that the IT professionals gave a value of 3.9. That means they were agreeing with the statement. Whereas the clinicians gave a value of 3, which meant they neither agreed nor disagreed with the statement. So we find in our work to date that IT doesn't work as well for clinicians, for ophthalmologists or for optometrists, as IT professionals believe it do. We asked a whole load of questions and elicited that there was a huge amount of desire for clinicians to be more involved with digital transformation. We also found that there was a general feeling that organizations were not prepared for the deployment of AI. And this was data from about 2 years ago. So after the initial rush of excitement, sort of 5 years ago, about AI and technology, our digital leaders then came to the realization that our organizations were probably quite a long way from being ready. So what happens as time goes by? As we have more and more digital services, as we're receiving more data from the patient's home and from community optometry practices, we end up with hundreds of thousands of patients using lots of different digital platforms to manage hundreds of different disease processes. That means we maybe end up with 100 different duty rosters. We end up with lots of platforms we need to train patients and clinicians to. We need to ask the question, who's going to look after these AI tools? There's a new workforce requirement. And the reason I talk about this is because it's an opportunity for every hospital in the world to improve, including us, which is that this is not the first time we've had this question. This was the first chest X-ray machine from the Glasgow Royal Infirmary up in Scotland, and we are mirroring in digital medicine now the same process that radiology went through 100 years ago, which is a new technology has come along with revolutionary potential, but as yet we don't have a really good structure for deploying that technology. We don't have the right professionals to do it, and we don't have the right training. So we've got, as a medical and an optometry community, a lot of work to do in terms of training our clinicians to be fully part of digital transformation. At Moorfields, we launched the Department of Digital Medicine a couple of years ago. That's been successful. We're now becoming an entire division of the hospital. So we're now growing to provide a lot more service than we previously did. We need to redesign our systems. Now, this is how I view shared care with optometry, how I would like it to occur in the future. And I've been using this slide for about 8 years now. And the exciting thing about it is that every couple of years, I can tick off one part of the technology requirements as having been available and embedded. So this is how I would like services that are offered from optometry practices, but require ophthalmic input to run. So we start with the patient, and rather than forcing that patient into a hospital clinic, we want to allow them to go to any place with the right equipment, with the right clinical expertise, and often that will be a high street optometry practice, to have their clinical data collected. Now, where that clinical data needs the support of a hospital ophthalmologist, we would like that to be done via a cloud-based platform. So we can tick those first 2 bits off now. We know that many optometrists on our high street have OCT machines and visual fields. That's very, very common in the UK now. And I've already shown you an example of a cloud-based platform that can help us to transfer that image back and forth. Where we would like to get to next is automated analysis of patient data. And we've got some really exciting AI algorithms coming through now, including Pierce Keen's work from Moorfields, which allows us to triage and diagnose from OCTs better than most ophthalmologists are able to do. Where it's simple, the next step will be to automatically drive a diagnosis and a management plan. Where it's complex, we would like the ability to hand that information off to a human clinician, because there will always be a role for very highly expert human clinicians in the process, who can then inform the diagnosis and management plan. And if we want to get really fancy, we would have to acknowledge that one of the major bottlenecks we have in our system is the amount of time a patient can spend talking to a doctor or an optometrist. We know that after a clinical consultation, patients remember about 50% of what they were told. We know that most consultations are too short, and with the greatest of respect for my colleagues, not every optometrist or doctor in the world is the best communicator. People have ended up in this profession for many different reasons. Some are brilliant surgeons, some are brilliant diagnosticians. Not everyone is good at explaining in simple terms to the patient what's going on. So maybe we could use a virtual AI-powered assistant. Now, I tried to do this about 5 years ago with the IBM Watson platform, and I have to say it was a failure. I ended up with a huge decision tree, which really just didn't work. And in conversations with patients, it very quickly went off topic. Now, we kind of know that large language models, ChatGPT, Google Gemini, Meta Llama, are really good at having clinical conversations with patients. There was a recent publication, I can't remember the journal, which showed that in an online forum where patients were able to ask questions to doctors, if some of those questions were actually answered by ChatGPT instead, and then clinical professionals rated the quality of the answer, the large language models performed better than the human doctors in answering some of the questions. And we've seen all sorts of coverage about these large language models passing medical exams. So we're possibly at the point where we are able not to replace the human in the communication loop, but to acknowledge that 10 minutes is never enough time to talk to your patient about a potentially blinding condition. And regardless of how good a communicator you are, that patient's going to have questions that come to them at 3 a.m. the next night. So we have the possibility in future to support our communication to patients with these automated processes, and we can plug in video consultations where we need to bring in a human to do that remotely. Redesigning our system is a challenge. So this is some work I did with the NHSX, which was the national organisation in England designed to drive digital transformation in healthcare. It only lasted a couple of years before it got shut down, so it was a little bit too radical. But what we envisaged was our current situation with the patient at the middle, and their care pathway is supported by these concentric rings. Around them, they have family and community. They have general practice. They have high street optometry, and they have the hospital around the outside. And when we mapped some of their care pathways against these rings, we found it was just total chaos. Patients were bouncing in an unconnected way from ring to ring, and it wasn't joined up. Our proposal, which I'll tell you about how it's going, was to come up with a new type of ring in the middle, which we initially called a digital ophthalmology hub. We then realized that was too excluding of our optometry partners, and then we called it a digital eye care hub. Now we call it a telemedicine support unit because we think it's useful for all medical specialties and not just ophthalmology. We envisaged this as being something that would sit between the hospital and all of the other support mechanisms for the patient to try and connect up their care and provide whatever expertise was needed wherever it was needed. We did our first pilot. So this goes back to December 2022. We did a pilot on wet macular degeneration in a part of London called North Central London. So London, with its population of 20-ish million, if you include all the bit around it, is divided into 5 integrated care systems: North Central London, Northeast London, Northwest London, Southwest and Southeast. So we started off with a pilot, just looking at collecting data and doing rigorous analysis on managing 100 patients with wet AMD referrals in that way. So instead of having the usual system where an optometrist or a GP saw a patient and suspected wet AMD and sent it to whichever hospital was nearest to them, we got them all to send those referrals to a single centralized place. We provided centralized reading from the Moorfields Reading Centre, led by Konstantinos Velasquez, which has got a team of hospital optometrists who work in medical retina clinics. And we provided instantaneous diagnoses. We bypassed first diagnostic trips into hospitals and brought patients straight in for injection. Where we diagnosed an epiretinal membrane, we provided advice to the referrer, so the patient didn't need to come in. And we worked in collaboration with all of the hospitals and optometrists in North Central London. And our purpose was to go from a very complex pathway on the left to a still complex but slightly simpler pathway on the right. And this is what we found from our small pilot. Just by centralizing our referrals, by engaging closely with our optometry community, we managed to get a third of our referrals with imaging, whereas previously it was only around 15%. So we doubled the number of referrals we got that had imaging attached. When we looked at the patients coming through our urgent wet AMD scanning clinics, we found before the intervention, only 38% of patients who didn't go through our single point of access were appropriately there. Whereas patients who came via the single point of access, 71% of them were in the right place and went on to have a diagnosis that needed to be treated. So we're making a massive impact on clinic capacity there by getting the right patients in the right clinic. We massively accelerated the process from a referral being generated by an optometrist to a qualified medical retina specialist having a look at that from 11 days down to 1 day. So we went from a 2-week service to a 1-day service. For our patients, we saved them travel of 22 kilometers and about 2 kilograms of CO2. We reduced the average number of visits from 2.3 to 2 by reducing unnecessary accident and emergency and general practice attendances. From 100 patients, we reduced the amount of paper by 1,000 pages because various parts of the system remain on paper. We did case-based discussions with every referring optometrist, and about a third of us took us up on the offer, but we did about 30 in the end. And that was where we took hospital optometrists with a special interest in medical retina, a medical retina fellow, and a small group of referring optometrists, and we discussed the cases that they sent in with us. And we got about a 95% satisfaction rate from our optometrists. And what we were able to do was use the referrals that they were sending in as an opportunity to engage with them and educate them, which helps them to manage those patients either on their own or send us better referrals in the future. We also developed a digital twin, which is now going on to become a comprehensive model of eye care in our part of London. We can use it to do all sorts of exciting things. We can use it to predict what the impact of opening a new cataract operating theatre in any location on North Central London will be on every other cataract theatre in North Central London. We can use it to understand where our referrals are coming from, which patients are coming from areas that are in areas of high deprivation, and those patients are likely to be excluded from traditional services. Our live service I can't talk about too much at the moment because we're going through a competitive bidding process to win some new business. So I'm banned from talking in great detail about this, and Eyecare is a small community, so I've been told not to talk in too much detail. But at the moment, we're live in over 100 optometry practices in North Central London, so we're connected up to those. We've seen a huge improvement in our ability to get referrals to the right place. We're able to reject about 9% of referrals, downgrade half of the urgent referrals to routine, and redirect 40% of the referrals so they end up in the right subspecialty clinic first time. We're generating significant cost savings to the whole system. We're running monthly education sessions like this one for our North Central London referrers. We only get 150 coming into every session. You guys get 300, so we got some catching up to do. We need to expand to other areas of London. We're generating lots of new understanding about what's important to our patients, how we can write to them better, how we can get them to healthcare services that they want most. We're identifying opportunities for AI implementation. I think a year from now, I'll be able to talk to you about some really exciting work we're doing with large language models on referrals. And we're getting towards what myself and many of my colleagues have wanted for a long time, which is a part of the healthcare system that's truly a learning healthcare system, which says, here is a complex system comprising optometrists, hospitals, independent clinics, and previously all the data was in different places. Now we're getting to a point where we're capturing that data, where we've got the ability to analyze it, we've got the ability to understand how we can improve and implement improvements. And I think we're developing some really good interventions that are going to impact the provision of eye care at a population and public health level in parts of London that we cover. So maybe a year from now, it'd be good to come back and maybe give you a bit of an update on how that live service is doing. We've managed getting on towards about 10,000 patients in the last 6 months through it. And I think we're going to be generating some very, very significant findings for how eye care is delivered globally. I think probably I will leave it there for my talk. I can talk for an awful long time about many of these things, but I'm keen to move us on to questions. That's my email address. If anybody would like to make direct contact, very happy to chat to you.
Wonderful. Thank you very much, Peter. Excellent talk. You basically covered everything from digital space to home management and to the future space as well. Next, we will move on to our panel discussion session. Of course, we will also have a Q&A. But before that, I would like to first introduce myself, and I beg everyone's pardon for not introducing myself at the start. I got too excited introducing Peter. So I'm Dr. Tan Lee Chong. I am an assistant professor at NUS. I'm also the Optometry Education Program Director at NUS Yong Yulin School of Medicine. And together with me today, we have Dr. Blanche Lim, who is an ocular plastic surgeon. She's also the co-lead for optometry education in our department. She's also the community eye care lead and champion for NUH. We also have Dr. Anna Yaw. Most of you here are familiar with her. She's a very experienced optometry educator in Singapore. She's now a senior lecturer in NUS, Yong Yulin School of Medicine. And without further ado, we would like to kickstart this Q&A session. And I believe we have some questions coming in. But before that, maybe I would like to invite my fellow panelists to ask some burning questions. I think they already have some on their notes. Blanche, Anna, go ahead, please.
Hi. Maybe I go first. Oh, okay.
Yeah, go ahead.
Blanche, you want to go first?
No, please do.
Yeah, okay. So Peter, it's really interesting to get to know the system, that you try to build up. In the first place, we work in silo. Usually hospital, they work on their own. The private optometrists, they work on their own. So in the first place, how did you get them to be involved in this co-management pathway? So that's my first question. And the second question is there any current guideline or regulation that look into governing the co-management of patients in UK at the moment?
So the first one's really interesting in terms of engagement with optometrists because you're right, we were incredibly siloed from our community optometry providers. We didn't have good intelligence of even who was out there. Which optometrists worked in which practices were offering enhanced services on different pathways. We were very, very disconnected from private optometry. And part of the reason for that is that historically, referrals in the United Kingdom, although many of them started with an optometrist, they used to have to go via general practice. So it was mandated that the referral had to go from the optometrist to the patient's general practitioner, and they were the ones who were allowed to send the patient into ophthalmology, which makes no sense at all because, as many general practitioners will freely admit, they probably got 2 weeks of eye education if they were lucky at medical school, and they're meant to be handling and screening referrals from highly educated, clinical professionals in the optometry workforce into ophthalmology. By having GPs in the way as a filter, it almost prevented us from forming those direct relationships. What we found was when we started to launch our single point of access, there was a huge amount of pent up demand from our optometry population. There were things they really wanted that we hadn't been doing for them. So they wanted to, so on the patients who they sent in, even if the patient went via a GP, they wanted to know what happened to them. So they wanted to receive the clinical correspondence after the appointment. They wanted ongoing education. They wanted feedback on their referrals. So we started offering those things. We offered them the things that they wanted in order to better manage their own patients and improve their own practice. And that was a very powerful way of engaging with them. We found via our teaching offerings that I think the first one we got about 70 or 80 optometrists, and then over the next few we sort of built up to between 100 and 200 just via word of mouth. Those are spreading around. And I think at some point we sort of take the shackles off and make it just sort of nationally open once we're confident we can deal with the volume. We found that. We found there was pent-up demand, and when we started tracking them and onboarding them onto our NHS email systems. So previously they all had their own email systems, which meant we didn't have a directory of them, meant we couldn't have secure clinical correspondence. We've started onboarding them onto NHS digital infrastructure. So it's a long-term process. It'll take us years to get there, but I'd like to sort of almost get my arms around them and bring them into the NHS infrastructure so they can see shared care records, so they can send referrals in our systems, and we can refer them in. In terms of governance, there's quite a few bits. So there's various sort of commissioning contracting mechanisms. So the minor eye condition service MECS and COVID urgent eye service queues are two sort of nationally adopted processes whereby parts of the country can get community optometrists to offer services within a certain scope. And some of those include co-management within them. We've also got things like the National Institute of Clinical Excellence that puts advice around referral transition from optometry into hospital. So there are the building blocks for how we co-manage. I would say that true co-management is still the exception rather than the rule. We've moved from, if anything's wrong with the eye, send them in, to if some things are wrong with the eye, keep them in enhanced services, but when it gets to a point where it needs an ophthalmologist, send them in. So that's where we are now. And the next stage is being able to track the patient as they bounce back and forwards between hospital and optometry services so that each person is inputting what they need. So I think we're getting there. We've got some governance, but we probably need a bit more.
Thanks. Very nice. Thanks for the answers. And I'm not quite sure, how we could apply to Singapore situation. I'm not sure whether Yi Chong would like to comment on that as well.
Well, I think we are starting on a similar scheme now in Singapore, where we are looking into co-management eye care model between the public health institute, public hospital institute, and the private optometrists in the community. So there's a lot for us to learn from your scheme. Uh, and on that note, actually, I'm just wondering, from having the idea to implementation, how did you guys go with it? Did you guys just implement, or was there a long process of tests and trials, or you guys just went with it and do your adjustments along the way? I'm just curious about that.
Yes, there's been quite a lot of work in different parts of the country. So people have piloted these. There are services set up in different parts of the country that co-manage glaucoma. Around Cambridge, for example, they co-manage glaucoma with a community. Problem is that none of it's ever scaled. There's never been a scalable model to really back these services. They've always relied on having a small number of really passionate clinicians in the optometry community and in the ophthalmology community in any given area to sustain these different models of care. So ours really came about because we argued with the sort of through our central NHS organisations that we needed to take all the learnings from these small services and work out how we could turn it into something scalable. And that's why we came up with this initial idea of the digital eye care hub. And we sort of built it from the ground up as something that could work anywhere. It didn't have specific requirements of technology or specific requirements of providers or the optometry community that meant it can only work in London or it can only work in the countryside. Rather, we tried to build a model that you could implement in any part. And that's where it came from. That's where the impetus came from. An opportunity came along in the north of London for us to take over from a provider that wasn't delivering in terms of managing some of that community care. So we took that over and we built it from there. It's been a very iterative process. We do something, we try it out. If it works, we carry on doing it. If it doesn't work, we change it, see if we can make it better. So we are very much learning as we go along with this.
I want to congratulate you. It's been a very, very informative talk. I think
Thank you.
I did read some of your papers as well. And what really fascinates me and impressed me in this session of yours is you brought upon your talk two very important elements. And I think one of it is rationalizing patient journeys. And I think a lot of us cannot it has been very underscored in a lot of our practice. We don't understand how frustrating it is for the patient. And in that way, I'm very impressed that you managed to even plant OCT machines all around and encourage this particular uptake. The second thing that really impressed me was also the fact that you have also brought in the element of sustainability. And I think this is something which, as a university, in NUS, it's something, especially as a department as well, is something that we are really interested in going in this space. And it's really encouraging that you've come so far. Before I start going on, I just want to find out in this whole journey, what for your personal journey, because you've come so far and you're definitely decades ahead of us, along ahead of the bell curve in this, what was the greatest challenge you faced in this? For us in Singapore, I guess, we do face a lot of challenges. One is definitely culturally in the ophthalmological spectrum and the optometry spectrum of things. Coming to work together as a collaborative partner is something that we are starting to find great value in. Second is the fact that we are very culturally diverse. So things like language, and I don't mean language models, but more of, when we converse in terms of what we mean, we don't quite mean our patients don't quite mean what they say because of their language capabilities, and may even come in a different language form as well. And so I picture, in future, if we were to adopt these digital forms or telemedicine forms of communication, this is something which we will have to employ ChatGPT or translational models to and put this in to become more diverse. But I just want to find out your perspective and how you think, what do you envision the next 5 years or 10 years will be for Moorfields or the UK in this area as well?
Yeah, I mean, the language one is really interesting because even now, I mean, things like ChatGPT, we can overestimate how good they are. They have their limitations. But if just as an example, if you if you write a really bad patient letter, so if you try and write a patient letter that's as inaccessible as possible, so, you know, I'm listing this patient for BEMR plus 5 millimeters under GA to treat, I don't know, their whatever, their committed esotropia, something like that. And you ask ChatGPT to explain it in language that an 8-year-old will understand. It does a really good job. And then you can ask it to translate into German. It'll do a really good job on that as well. So I think communication, I think there's going to be a huge, I think that's where we're going to see the first big impact of AI in healthcare. I think we've spent a lot of time thinking about very clever models for diagnosis, which will have an impact, but they'll have an impact on individual clinical niches. I think what we'll see as a sweeping one is that it will allow our clinicians to communicate way better with patients without having to try. So if you look at work that Microsoft are doing with Nuance and a forthcoming product they have called DAX Copilot, where you can dictate a letter, it'll extract structured clinical data from that letter, and then you can imagine it simply writing 3 different versions of your clinic letter for you, one for the GP, one for the patient, one for your colleague who'll see them a few months down the line. In terms of the biggest challenge that I faced, I think it was really understanding how different optometry is from ophthalmology. You know, I've sort of, you know, my training was sort of Oxford, Cambridge, Moorfields. So I was always very much, you know, embedded in very traditional views of medicine, very traditional views of ophthalmology. I really had no understanding of optometry as a profession. And my view going into it was, well, you guys have got all these OCTs, you've got these scanners, just give us the data and we'll do it. I didn't understand what the limitations that optometrists face in their clinical practices, which is that, you know, they need to operate a business model that is financially viable because they're not part of the NHS in the same way as we are. There's a cost for them associated with buying an OCT machine, and they need to realize that cost. They can't just give away the scans for free. They get paid a certain amount to send a referral, and that amount they get paid is too small for them to be able to take lots of scans and provide lots of extra information. So I think for me, the major challenge was understanding that I just didn't fundamentally understand the eye care system. I thought I did because I was an ophthalmologist. I now realize I didn't because ophthalmology is only a small part of it. And that's what's enabled our current service to run well, is understanding not just what the needs of ophthalmology are, not just what the needs of the patient are, but also what the needs of optometry and other parts of the system are. So I think that's been key for it. The next 5 years, I hope it will just go from strength to strength. I hope we'll start embedding this nationally. We'll start onboarding our optometrists onto the NHS's systems. So all referrals are coming on a single system. So we have a single source of truth. That will start rolling out AI to help the system work more smoothly. I've got some really exciting implementations of AI coming up in our referral management, which I hope to talk about in the future. I think we'll start to see things become more efficient without anything changing very much within the hospital. So the patients who will be in hospital, that'll still look pretty much the same, but the whole system, I think, will work better and more efficiently as we apply technology. But critically, do we think about the services we're delivering, not just the technology that underpins them? We design a good service and then we use the right technology to make it work.
Thank you.
Excellent. Right, Peter, there's one question that's relevant to what you mentioned just now. Of course, eventually you hope to have optometrists in not just London, but UK to come on board, be part of the NHS. But at the moment, how do you guys handle the transfer of data, given that there's data protection considerations, and this is beyond hospital level IT system as well? And in addition, how is the IT cost being shared? Does the community optometrists need to bear some of those costs as well?
Yeah, that's a really good question. So I think the challenge has been historically, whenever we've seen, it's been private companies that have stepped in to connect up optometry to hospitals, and they've used their own digital platforms, and some of them have beautiful functionality, but the problem is they create a data silo. The data about that patient referral only exists on that platform. You don't have access to the data on that platform to know how referrals are flowing. If you don't know how referrals are flowing, you can't design your system. You can't be sure that referrals are flowing in a way that the NHS would want, for example. Are referrals necessarily getting through to the right place? So my approach has been, in order to minimize the costs to optometrists, but also achieve what our healthcare system needs, which is an overview of what's happening, an overview of the flow of data, flow of referrals, that we've been onboarding optometrists onto NHS infrastructure. That means we're getting them on the NHS email system, which seems like a small thing, but it's actually a huge thing. It means that we can have clinical conversations with them without worrying about sharing patient information. It means that we can email them the letters after the patient's been seen in clinic. It also means we can track them. They will appear on an address book, so we know if we want to contact an optometrist at this practice, we can search for the optometrist in that practice and we can see a list of 3 of them. Our electronic referral system, which we have one for the whole of England, onboarding them onto that will give us consistency and standardization and mean that we have an open market for where referrals get sent to. It won't be possible to hide referral routes. So you have an independent sector provider over here with a special arrangement with an optometrist, and all the referrals go between the 2, even though it may not be what's best for the patient or system. So that's good as well. I also want to bring optometrists onto the NHS's shared care records. So we have a One London Care record that contains information from hospitals, general practice, mental health, social services. I would like to get optometrists having access to that as well. By doing it in that way, it's free for optometrists. They've got no infrastructure costs. They have to spend a little bit of time going through what's called a data security and privacy toolkit, where we have to ask them lots of questions about how they run their IT to make sure that it's not unsafe to give them their IT systems access to the NHS. But it's worth it. It takes the cost overhead off the optometry practice.
Excellent, smart move. So the lesson here is start small and start right. Start with email.
Yeah, exactly. It's the email's been transformative. We're getting, of our 6,000 referrals, 5,000 are come via email. We've had to do lots of automation to make sure it's safe, but optometrists love it because they can fire off a referral in 30 seconds, whereas if they use a digital platform, it's 4 or 5 minutes. So it really saves them a huge amount of time. So we're moving off email, but we'll always keep it there. It's a very useful thing.
Oh, excellent. And here's another question. Now, given that you guys are partnering more community optometrists, and obviously they're doing more imaging, the color funders follows the OCTs. Are you seeing more referrals from the community optometrists? And amongst those referrals, are there a lot of false positive referrals?
Yeah, quite a lot of false positive referrals. So we find from our advice and guidance services about half the time it's a referral with a disease that we can manage with advice with the optometrist. But because we're getting those images, it means that we can provide that advice before the patient comes in. And the nice thing as well is that each referral is an education opportunity. So each time a request comes into our advice and guidance service, we can respond with a description of what the image shows, with a suggestion of how that patient should be managed. So if it's a mild epiretinal membrane, see them again in a year, let us know if anything changes, that kind of thing. So each of those is an opportunity to deliver education to the specific referring optometrist. And we take all of our learning on a macro level of what referrals are coming in, and we use that to design our monthly teaching sessions. So our last teaching session was around pupils, palsies, and swollen discs, because they're a very common cause of referrals. Our next one's around emergency presentations. We had one about pitfalls in deciding whether your patient was a vitreoretinal or a medical retina patient. So we do get false positives. I think we'll see false positives reduce over time, but we also quite like getting false positives because each of those is a teaching and an engagement opportunity. So I don't mind receiving requests for advice where the advice is patient doesn't need to be seen, because it's an opportunity for improvement.
Actually, there's one question there, which I'm quite interested in discussing with you as well. I see Daniel, one of our low vision optometrists, has actually raised a very interesting question, and I do want to also raise this up. The UK has also been very, very advanced in terms of providing low vision care and the support for this. And in particular, we also know the low vision community to be the orphans of ophthalmology, wherever we are. In this area, in this space that you have, has there been any attempt, or is there any roads that you've made with partnering our low vision community in this, and whether there are any plans in future, if not?
So yeah, we're on from the services we run. We're very keen on signposting incoming referrals to low vision services. There's been a process of sort of rolling out, it's probably the wrong word, recruiting eye clinic liaison officers, which are there specifically to be the liaison between the patient and the eye clinic, and particularly for patients with low vision. There's still not enough of those. There should be many more of them. But I think things are gradually moving in the right direction in terms of low vision services. I think probably what we need to do, and again, it's something I didn't mention about joining up. I talked an awful lot about joining the hospital up with the patient at home and the optometry practices, but there's a huge amount in what we call the third sector, so voluntary and charitable organisations. So the RNIB, the Royal National Institute of the Blind, for example, we're working very closely with them in our work at the moment. So from our referral work, we have a project called the Letters Project, where we're conducting qualitative research with patients via interviews and surveys to understand their accessibility needs, and that includes low vision, and then designing better ways of communicating with them. And also, I hope we'll then be able to start signposting significant numbers of patients at the point of referral to low vision services. So I think we're making some progress, but I think, like everything else, there's probably still quite a long way to go.
So Peter, in the interest of time, I think we'll take one more question. I see one that is relevant with a recent conversation that I had with Anna. It's about trust. Trust for between optometrists and ophthalmologists. And Anna, would you like to further elaborate on that?
Oh, yes. Yes. Now, what happened is that in terms of trust, optometrists kind of become a little bit resistant in terms of receiving training from the ophthalmologists. Some, a small group of optometrists, they have this concern about, learning learning or being trained by the ophthalmologists. Whereas the ophthalmologists themselves, they may also have some issue of trust in terms of the skill set and knowledge level of optometries. So we have this problem here in Singapore, and that's why, for the longest time, we haven't been able to move forward in terms of collaboration and cooperation between the two professions. So what kind of advice do you have for us, Peter?
Yeah, I think that situation probably exists everywhere, and some of it's probably natural. Whenever you have two different professional groups, there's always going to be a certain degree of competitive tension. I would say I think we're probably in quite a good place when I sort of look around internationally in the United Kingdom. One of the drivers for that has been that we simply don't have enough doctors in this country. So we have brought through many optometrists into hospital eye services. So at Moorfields, we've got about I think we've got about 160 consultant ophthalmologists, and we've got about 170 hospital optometrists. And those hospital optometrists aren't there to do refractions, although some of them do refractions in the pediatric service, for example. They are managing glaucoma patients. They're managing medical retina patients. They're managing cornea patients. Our service director for our keratoconus service is a hospital optometrist. So one thing we've done is really embrace the optometry community into hospital ophthalmology. That means that when I recruit patients into my single point of access recruit clinicians into my single point of access for referrals, I've got a brilliant group of hospital optometrists to choose from, and many of our hospital optometrists also work in the community. So we've got that ready-made bridge. So that's been really important. There's also been a move over the last 20 years or so, maybe slightly longer, to make optometry training in the UK quite a lot more clinical. To provide quite a lot more clinical training during optometry. And also there's some parts of the UK where there's lots of independent prescribers. So optometrists in the community who have independent prescribing rights to give a certain formulary of medications. And again, I think that helps both sides, both ophthalmology and optometry, to understand that at the end of the day, they're both clinical professionals involved in the care of the eyes. They have different areas of expertise. Ophthalmologists can do some things that optometrists can't, and optometrists can do some things that ophthalmologists can't. But I think the fact that we've been working together in that way is helping to break down barriers. There's always tension. So a lot of it arises from business models as well. We're a national health service, so we're provided not for profit by the state, whereas optometrists are individual businesses, and they need to respect their bottom line. So whereas we might say to a GP, send me any images you have of this patient, and we would expect the general practitioner to do it, step out of the NHS. We can't have that conversation always with optometrists. But what we do find is that we can have that conversation with individual optometrists. Most of our optometrists now consider themselves first and foremost to be eye care clinicians. So when we engage on an individual level, we find that generally they are very happy to spend extra time making sure the referral's good, to go to the effort of attaching the image. When we engage with them on a more sort of business or professional network level, we find that some of the sort of protectionism around commercial models have come in. But on an individual level, we're finding increasingly that the clinician-to-clinician connection is overriding a lot of those other ones. So it's not perfect. There's tensions here as well as there are everywhere. But I think we're doing pretty well at the moment in sort of moving in the right direction.
Thanks very much, Peter. And I think on that note, it's a very good point for us to round up this session as well. So first, very engaging session, great questions from the audience, and I see a lot of familiar names. We have 380 participants here, and I see a lot of friends and colleagues, optometrists and ophthalmologists as well. So I think there is a shared willingness to make eye care landscape better for Singapore. And on that note, I would just like to mention that in Singapore, we now have started a scheme, and in fact, this is an MOH-initiated scheme. It's called a Clinical Optometry and Community Screening Program, looking into partnership between Public Health Institute and community optometrists. So that is what Singapore is beginning to do. And on that note, of course, in NUS, we are trying to do a different kind of optometry education as well, and bring in the best of people, both from optometry and ophthalmology as well, having joint faculty from two domains, because there's so much we can learn from each other. And as you rightly mentioned, Peter, like for example, yourself entering the optometry domain, you realize that there are a lot of experts we can learn from one another, and this is what we hope to achieve here in Singapore as well. And in the next few months, we will be starting some clinical optometry program at NUS, and actually we are taking some few leaves of knowledge from Morpheus as well. So looking forward to engaging with you and your team in the future. Right, I think we are a couple of minutes past 7:30, but once again, thank you so much for staying until the end, and thanks very much again, Peter, and we look forward for future interactions with you and your team.
Thank you for having me.
And before we officially end this, I would like to mention that next month, on the 12th of March, we have another webinar, and the next one will be on myopia. It's by the world-renowned myopia expert, Professor Catherine Rose. She'll be giving us a talk on prevention of myopia. So please stay tuned for the March webinar. So with that, I would like to thank my fellow panelists as well, Dr. Blanche Lim, Dr. Anna Yaw. Thank you very much once again, and have a good night, everybody. Thank you.